Audio Jungle.
Hello, I'm Penny Tuffin and I'm an Advanced Practice Pharmacist in Palliative Care, and today we're going to talk about delirium in people with palliative care needs.
Jungle.
Delirium is a very common symptom across all of healthcare. It's particularly a problem for people when they come into hospital, and it's a frequent complication of an acute medical illness. In palliative care, it can be even more frequently seen. One study showed that on admission to a palliative care unit, up to 40% of people may be experiencing delirium. That number can increase during their stay, and by the time they're in the last few days of life, the prevalence can be up as high as nearly 90%. So it is certainly a symptom we need to be aware of, know how to assess and manage to keep people safe and less distressed. So the key features of delirium are outlined by the DSM-5 criteria. And these say that if you have delirium, that it will be shown in a disturbance in your attention and your awareness of your situation. Delirium generally develops over a short period, and it's a change from your normal baseline cognition, and it can fluctuate even during the day. There's generally an additional disturbance to your cognition, so you may have memory impairment, you may have hallucinations, you may not be quite comprehensive for what's happening around you, you may have word finding difficulty and difficulty with finding the right phrases. It has to be a condition that's not explained by any pre-existing condition that you have or any established or evolving neurodegenerative disease that the person may be suffering from. There also must be evidence that it's caused by a medical condition, and that can also include substance use, intoxication, or withdrawal from illicit drugs or medication. The other additional features of delirium are that it may include psychomotor behavioural disturbances. These can mean the patient can be hyperactive, so actually very lethargic, sleeping a lot of the time, or it may be represented by hyperactivity, where they're actually very restless and moving around all the time. There usually is an impairment in sleep, one way or the other, and the two types of delirium can be mixed as well. So people fluctuate during the day to being hypoactive to then being very hyperactive at certain stages. There's often a visible and variable emotional disturbances. People can be very fearful, they can be paranoid, they can be depressed, they can be just totally perplexed by what's going on and not comprehending what's happening around them. Terminal restlessness is a particular type of delirium that will occur in the last couple of days of life. It is very, very prevalent. Up to 90% of patients will experience delirium in their last few days of life. It's very distressing for the patient, but in particular for the family and loved ones around them, to see the person so restless, so agitated, and unable seemingly to get comfortable. We know that it certainly increases the risk of anxiety in the family, and also increases the risk of them having a complicated bereavement after the patient has died. It's also really important for us to distinguish between delirium and dementia. Delirium is generally an acute and fluctuating change in mental status, whereas dementia occurs very slowly, often over many years, and it's a very stable deterioration. For patients with delirium, their conscious level is usually impaired, whereas for dementia, patients are normally conscious and functioning throughout the day. The attention of people in delirium is compromised, whereas for people with dementia, they initially, in the earlier stages of dementia certainly, are able to concentrate on tasks. Hallucinations are the other distinguishing feature of delirium compared with dementia, and it's very common, particularly in people in their last few days of life, for them to experience hallucinations. There's lots of causes of delirium. Fluid and electrolyte disturbances can be enough, so dehydration, low sodium levels, high calcium levels are all things that can affect the person's chance of having delirium or experiencing delirium. People with sepsis and infections are often delirious acutely before their infection can be got under control. People with alcohol and drug intoxication often display symptoms of delirium. Lots and lots of metabolic disorders are associated with acute delirium. Slow perfusion states, so when people are in shock or they have heart failure, their blood is not circulating as well and they can suffer from delirium. There's a range of medications which I'll discuss that can cause people to have delirium, and also withdrawal from alcohol, from medications and from illicit drugs can all contribute to a patient suffering from delirium. So some of the medication groups implicated in delirium are listed on this slide, and you can see there's a very wide range. It ranges from anticonvulsants, any drug with an anticholinergic adverse effect, the Parkinsonian drugs, alcohol, antipsychotic medications, opioids, particularly in a palliative care environment, are often implicated. Benzodiazepines, corticosteroids have a high risk of causing delirium, particularly in people who may be prone to some unstable mental disorders. Cardiovascular medications, non-steroidal anti-inflammatory drugs, H2 antagonists, so drugs like ranitidine, and some antibiotics as well can cause delirium. Just to give an idea of how frequently this can occur, we can see that patients taking benzodiazepines are 3 times more likely to suffer from delirium than someone who's not taking a benzodiazepine. Opioids also are at a high rate, so 2.5 times more likely if you're taking an opioid for you to have symptoms of delirium than if you're not. The dihydropyridines, calcium antagonists like amlodipine and verapamil are associated with a high rate, as are the sedating antihistamines. But other drugs also at a significant high risk are the H2 antagonists, tricyclic antidepressants, Parkinson's drugs, steroids, non-steroidal and anticholinergics. Withdrawal is also something we must consider if somebody has presented with delirium. Many medications as well as social drugs, when patients are withdrawing, they will exhibit signs of delirium. So benzodiazepines again are right up there. If a patient has been a long time user of benzodiazepines, they may not actually mention that on their admission to hospital, and then if those drugs are not prescribed at a dose equivalent to what they've been taking, they may become very delirious because they're not getting their benzodiazepine. The same with nicotine and with alcohol. And we need to be very mindful of these social drugs, particularly in a palliative cohort, who may have to come into hospital because of a flare in their symptoms, but they're then not able to smoke and drink like they normally would. So we need to provide medication to alleviate that or facilitate ways that they can at least have a smoke. So somebody may need to take them out to a garden for a cigarette. Other drugs that are implicated in withdrawal are antidepressants, opioid medications, and of course a range of illicit drugs. And it's often in our medication history when people come in, we can miss things that patients don't consider as medications they need to tell us about. So the most important element of controlling delirium is actually looking at preventative measures and considering these for every patient who comes into an inpatient facility. We need to modify the risk factors. So we need to make sure that we keep people orientated, and we can do that by having clocks in the room, by having calendars, by having windows with outside views so people know whether it's night or day. And it may mean for an elderly person in particular to keep reorientating them, keep reminding them that they're actually in hospital. Cognitive stimulation is really important, and simple things like having visits from family and friends that they're familiar with will keep them cognitively stimulated, keep them having conversations with people that they're familiar with on topics that they're interested in. We need to make sure we avoid sensory overload for people when they come into hospital. It's a foreign environment, and although most of us who work in that environment are used to it, for people coming into a hospital it can be very, very disorientating, particularly at night time when they're not in their normal bed. There may be other people sharing the room with them. They may have to get up and move down a corridor to go to the toilet. They may need reorientating quite regularly. The facilitation of a normal sleep pattern is also vitally important. It's very easy for people when they're in hospital with nothing to do, no one to interact with, that they will just doze during the day, making it very difficult for them to sleep at night. And it's very important that we have a normal wake-sleep routine. So we need to make sure that during the day the blinds are up, it's light, we are interacting with people on a regular basis, and then the reverse is true at night. We keep lights down, we try not to disturb people during the night and let them have a decent sleep. Other modifying factors to try and prevent delirium are to keep people as mobile as possible, so get them up doing regular exercise, even just walking up and down a corridor. Making sure they've got their glasses and they've got their hearing aids so they can see and interact and also hear what's happening clearly. We need to always do a medication review and try and avoid or minimise medications that may be implicated in causing delirium. We need to treat any medical complications if it's appropriate for the person at their stage of disease. So if a patient has an infection, we might want to treat that with antibiotics to reverse the chance or minimise the chance of them having delirium. Whereas if they're in their last days of life, that is probably not as appropriate. And we absolutely need to manage pain. Pain is a very rapid progression into delirium for many people, so making sure their pain is under control, asking them about that and treating it appropriately is important. There are a lot of validated screening tools which we should be using for every patient who comes into hospital, and different institutions will use different tools, but it's good that we've got some well-known, well-documented and accredited, validated tools that we can use. And these, as I said, are screening tools. They're not assessment tools, but they at least give us an idea if somebody may be slipping into delirium, and we can take action very quickly. So a general assessment will involve a clinical assessment of any precipitating causes the patient may have. We need to do a clinical examination and make sure we're not missing something, like the patient's in pain and just not reporting it, or they have an infection that could be treated. And we also need to assess the level of distress of the patient in their delirium, but also their family members. So our first step of management in delirium is to reverse any reversible causes that we can find. So for example, we might want to cease or wean contributing medications if appropriate. We may need to provide oxygen to a patient who's hypoxic. We might need to treat hypercalcemia, and hydration is very important for somebody to keep their cognitive state impaired. So it may be appropriate for people to make sure that they are actually drinking, or we may need to give them artificial hydration. In the terminal phase, there's different elements that we might want to consider. Pain being one, we need to assess and monitor their pain levels all the time. We need to check that they haven't got urinary retention, a very common symptom in the last few days of life, and often people may need to have a catheter. And we need to assess for constipation, again very common in our palliative care cohort, and it's something that we might not have been addressing so carefully in the last days of life. And it may not be appropriate to treat constipation at that point, but we certainly need to assess and decide if it's a contributing factor and whether it is appropriate to treat or not. Other management strategies that we need to bring in are still very important, so practical things like checking on the patient regularly, making sure they are orientated to time and place, making sure that we have the clock and calendar that are visible and in a place that's easy for the patient to see, decreasing noise around them, providing a single room if at all possible, and having personal items around them. People often find when they're visiting that things like a photo album and going through that is a very good reorientation tool for someone with delirium. We need to make sure that light at night time is as a lower rate as possible, have regular family visits, make sure they have got their glasses and hearing aids easily accessible for them for when they need them. And we need to make sure that we are not cluttering their environment with equipment and things that are foreign to them, and it can be actually quite disturbing. and avoid excessive staff changes if we can. It would be, in an ideal world, we would have the same nurse looking after the patient for each shift. But of course that's not going to be practical, but trying to have as least number of changes and different faces is going to be beneficial for the patient. Management also involves educating and supporting the patient and their family. When they're frightened and distressed, we need to actually reorientate them, but also give an explanation. Patients will often know that they are confused, so reassuring them that yes, we know they're confused and we're trying to help them and keep them safe can be very reassuring. We need to support the family as well, explain to them why this is happening, and what we're doing and what they can do to try and minimise the impact of the delirium. So there are several medications we'll use for the management of delirium if we haven't been able to control the symptoms and the distress of the patient using non-pharmacological therapies. The most common that we will use in palliative care are antipsychotics and the atypical antipsychotics. There are other medications that are used in other places within a hospital environment, but we're not going to spend time discussing those today. We also use medications particularly in the terminal restlessness, so in the last days of life, and these include haloperidol, benzodiazepines, also levomepromazine and phenobarbital. Levomepromazine and phenobarbital are medications that will generally require a specialist input. Levomepromazine is a potent antipsychotic that affects many receptors within the body. It is also only available on the Special Access Scheme and therefore will require application to the Therapeutics Goods Administration for use. Phenobarbital is a sedative barbiturate. Again, it is something that is used by specialists and specialist input should be asked for. So haloperidol is the medication that we reach for most commonly when we're talking about delirium. It's very important that this drug is only used if other modalities haven't helped, and we will try and use low doses for the shortest period of time possible. Haloperidol is a high-potency antipsychotic. It's relatively non-sedating compared with other antipsychotics, and so often we may need to use a benzodiazepine as well if we feel that sedation is needed. It does have a range of adverse effects, extrapyramidal being something that we need to be very careful that we're not inducing in a patient, and we need to assess very carefully. It's rare at doses of less than 5 milligrams per day, so we absolutely need to keep our doses low. Postural hypertension is something we need to be aware of, particularly in a patient who's delirious and restless and trying to get out of bed. It's going to affect them and can drop their blood pressure rapidly. It has anticholinergic side effects as well, although often in the very low doses we're using these are minimal. QT prolongation is important to consider, particularly if we're also using other medications that cause QT interval prolongation. The doses we used, as I mentioned, are very low. We'd often start at 0.5 of a milligram subcutaneously or orally on a PRN basis, and hope to certainly not give it any more frequently than 4 to 6 hourly. In the elderly, the dose can be even lower. As a reminder of what the extrapyramidal effects are, we have the acute dystonic reactions, which are usually fairly easy to pick up. The patient will experience these within hours of having the medication. It's the other side effects that we need to be a lot more vigilant in looking for, because they can appear days after we start the medication, but can be just as distressing for the patient. Atypical antipsychotics includes a wide range of medications, and the ones that we're most familiar with are risperidone, olanzapine and quetiapine. Each of the atypical antipsychotics have a varying receptor affinity and across a broader range of receptors than haloperidol. So they'll have effect on dopamine, serotonin, histamine and muscarinic receptors. And this becomes important in choosing which antipsychotic we may want to use. The atypical antipsychotics were initially named that because they have a lower rate of extrapyramidal side effects. However, they're not without extrapyramidal side effects, and many studies show that these medications may have a rate of up to 25% of patients may suffer from some extrapyramidal adverse event when taking these medications. These are available as oral formulations only, with the exception of olanzapine, which comes as intramuscular injection. So it does limit our use, particularly in terminal restlessness. Risperidone is actually licensed for use, is the only one that's licensed for treatment of aggression and agitation in people with Alzheimer's disease. Whereas the others are all off-licence use, as is haloperidol in the treatment of delirium. The doses are very low again, 0.5 of a milligram once or twice a day for risperidone, and we would normally start on a PRN basis. We can increase the dose, but generally we need to do that very slowly and would not increase it any more frequently than every second day. Benzodiazepines are the other medication that we may consider using in a patient who has delirium. They may be required, particularly in the terminal phase. They are useful for reducing anxiety as well. They will also treat myoclonus or seizures, which can be part of the delirium spectrum, but they may also be unrelated. They may be because of the patient's disease status. Benzodiazepines are also a muscle relaxant, and that can help with patients who are particularly restless and agitated and moving around the bed. And they are, of course, sedating. In general terms, we won't use a benzodiazepine alone in treating terminal restlessness. We will normally use it in combination with a small dose of haloperidol, and that's because it's high chance of causing extra delirium. The benzodiazepines we may use are lorazepam, which can be given sublingually. The dose we'll use will be small, 0.5 of a milligram. It will work generally or have some effect within 5 minutes, but it has a long half-life, so we mustn't be dosing too frequently. We'll frequently use it on a PRN basis, and that may be up to only twice a day the patient may require it. Clonazepam is only indicated for epilepsy, but we may choose to use this medication in the terminal phase because it will last longer. So it means that we can have a patient much more settled for a longer period of time. It will work reasonably quickly if we give it sublingually. It will reach peak effect within about 15 minutes, but may start to have an effect after about 5 to 10 minutes. And its duration effect is generally at least 12 hours. There are some difficulties with giving it subcutaneously in that it may be irritant and it may not, or the whole dose may not be absorbed, but by titrating to effect we can minimise that problem. Dosage-wise, we would normally start with a 0.5 of a milligram dose, and that can even be our once daily dose. We may, on occasion, want to give it via a subcutaneous infusion, and again, we will probably start at a very low dose of 0.5 or 1 milligram, unless there's other reasons, such as the patient is having seizures, where it would be appropriate to use a higher dose, even up to as much as 6 milligrams a day. Midazolam is our fastest acting benzodiazepine and also the drug with the shortest duration. Its onset will be quick, within about 5 minutes, but it will only work for about 1.5 to 2 hours. The advantage of midazolam is that it also has an amnesic effect, so the patient will actually forget that they were feeling confused or delirious. It's only available as an injectable form. It is licensed for subcutaneous administration, so it can readily be given that way. Our dose range will be very small. 1 milligram will frequently be our starting dose. We give that dose, we see what effect it has, we monitor the patient carefully and may need to repeat the dose, particularly the first dose, as quickly as 1 hour after giving it. We can put the medication in a syringe driver, and often we'll be looking at doses as low as 5 milligrams over 24 hours, up to probably a limit of about 60 milligrams over 24 hours if the patient is particularly delirious and confused and actually at risk of causing themselves harm. So in summary, delirium and terminal restlessness are both very common in people with palliative care needs. We need to make sure we do a really clear assessment and identify any contributing causes. We may be able to reverse those, and certainly should if we're not in the last days of life. We need to explain what's happening to the patient and support the patient and family through the instance of delirium. Non-pharmacological therapies are the most important in terms of preventing delirium, but also in managing it once it starts. And sometimes we will use pharmacological management if we have a particularly difficult to manage delirium or we feel the patient is at risk. We always use the lowest dose possible and for the shortest duration possible. Thank you for watching this presentation today.
Audio Jungle. Audio Jungle.